The views and opinions expressed on this platform are of me, myself, and I, not any agency I'm affiliated with. So please do not take what I say personally. I want to start off and thank everybody for the overwhelming amount of positive words, encouragement, your text, your DMs, however you've gotten a hold of me. I really do mean it when I say that I am completely floored at the people who in EMS, not in EMS, who have taken the time, listened to these podcasts, and then told me like, "Hey, this is great," or "Hey, I really like where you're going." It means the world, and it's so cliche to say that, and I'll say it time and time again, but it really does mean a lot. I appreciate it. Um, Sorry, I had to re-record that. I'm not getting emotional. I don't really, like I've told people, I don't expect this to really get big. I don't expect it to get, you know, I don't expect this to be to where like thousands of people listen. I'm not looking for that, but if people are listening and like we're talking about stuff, whatever, it makes me feel really good. And maybe it's just this is a giant ego stroke. I don't know, but thank you so much everybody who's reached out, contacted me. I really do hope that this gets better. I hope that we learn along the way and like it's done, we continue to facilitate conversation and start asking questions and start talking about things because I'll bring up stuff and like I say in the beginning, like this is opinion based. This is not factual evidence 9 times out of 10, but I have opinions and I want to talk about this stuff. And I feel like there are other people out there who do as well. And I mean, my people not in EMS, like, thank y'all so much. You really don't have to listen to me. Sometimes I don't want to listen to me, but I don't know if it's your general curiosity or if it's just again your support. Like, thank you for being here. I appreciate you. I had to re-record this entire thing about 3 times because I start choking up. Like this, I'll get off of this, but this podcast was meant for a kind of outlet, a hobby more or less, because I don't know how to self-care. I don't know how to take time for myself. And this was gonna be that thing for me to kind of keep me preoccupied, whatnot. But I feel like it's turning into something else where I feel like I'm giving to other people and it gives me life. Speaking of facilitating conversation, I did have people reach out to me and ask me about the tangent I have with Narcan in a code. I was a little harsh in saying that it's dumb, but also I feel very strongly about this. But I finally found the article from the AHA that kind of backs up what I'm saying. And everything that I've said is, and everything I'm going to say is based off of this article because one, it's the AHA, American Heart Association, which gives us our ACLS algorithms and all that stuff that we use in these codes. But it is evidence based, which I'm not a proponent of all things evidence based. Your protocols are going to save your bacon. I'm going to talk about that in this episode. Going back to my main point, it is a solid article. I have the link posted in like the show notes or whatever you want to call it. I don't know how this works, but it's posted if you want to go look at it. I don't even like really fancy medical articles because it's a whole lot, it's overwhelming. But this is one I actually sat down, looked at, read, and everything I'm about to say, I'm taking from this article. 20 out of 10 recommend. First off, when you have a cardiac arrest, meaning that you have confirmed that the person is pulseless, you confirmed that they're not breathing, all that stuff, the first 2 things you do after making sure that they're not like bleeding out or anything like that, the first 2 things that you do, you start chest compressions and you get an airway, whether you're just throwing down an OPA to keep the airway open and you're bagging. Those are the first things you do. And it's something that an EMT can do, an EMR can do, whatever the layperson honestly can do. I'm not saying that I've had somebody bagging a patient before that had coded that was not part of the EMS crew that we were part of, but they're able to do it. Desperate times call for desperate measures in rural EMS. Your lifeline to this patient, besides all the cool things we can do, all the defib and medications and this, that, and the other to facilitate trying to obtain a circulation back on this patient, get them back, is to do chest compressions and establish an airway and breathe for them with high flow O2. Secondly, the first thing you give in a cardiac arrest is epinephrine 1 to 10. If you're giving Narcan first, you've missed it. I'm not going to sugarcoat that part. You need to give epi first, and it is literally in the American Heart Association Advanced Cardiac Life Support ACLS algorithm. If you miss that, you're behind. I had somebody bring up that in the H's and T's, which are like, oh my God, there's so many: hypoxia, hypovolemia, hypoglycemia, all this stuff. And then you got your T's, which are like your toxin overdose. You got tension pneumothorax, so many things. Um, in the H's and T's, that it's indicated that we give Narcan to facilitate, eliminating the reasons why this person went into cardiac arrest. I want to point out, opioids are not cardiotoxic. Opioids do not hurt the heart, they hurt the respiratory drive, which sends the person into cardiac arrest. And this is where I'm going to start bringing up that article from March of 2021, so it's relatively still up to date. And I'm paraphrasing this part, but Narcan is going to bind to the opioid receptors that will stimulate the respiratory drive. So when you give it with the hopes of, well, it'll get them breathing again, yes, but this will not work because the heart's not working. So, like, in that article, it does say in some animal testing, Narcan protects the heart against ischemic damage. However, it also states that some causes of out of hospital cardiac arrest are not reversible with opioid antagonists, such as Narcan, and require other therapy. The article even states there are fundamental differences that exist between anoxic perfusion in out of hospital cardiac arrest and sudden ischemia produced by cardiac causes of out of hospital cardiac arrest. Anoxic perfusion causes more severe brain injury during ischemia and reperfusion, meaning the hypoxia is what's doing the bad things. It's not that the opioids are doing the bad thing, it's that the opioids, again, cause the respiratory drive to decrease and then stop altogether, which causes the cardiac arrest, wherein the heart has stopped. Continuing on in the article, it says numerous animal studies have demonstrated neuroprotection and cardioprotection associated with opioids in the setting of cardiac arrest. In most studies of experimental brain ischemia, reversal of opioid binding with antagonists such as naloxone worsened brain injury. Moving on, opioid antagonism, particularly at high initial and total doses, is associated with pulmonary edema. And this is my take. Again, do not slam Narcan. I'm even going to take it as far as to say don't even give high dosages at a time with each dosage that you give, because if you slam it, not only, like I've said before, I've seen flash pulmonary edema with high doses of Narcan pushed at one time. So when you slam it, you're forcing your patient into the sudden withdrawal because you're binding the receptors of the opioids, which is the antagonist, and it's taking away like the effects of the opioid and what all it's doing. And they go into sudden withdrawal, and the body literally doesn't know how to handle. And it can even send them into a seizure. So you have your patient seasoned, then you got to give a benzo like Ativan or Versed or whatever you got to control stated seizure. So you're just taking the respiratory drive yet again. And we're going to go back to giving Narcan in a code, but in a patient with a pulse, the whole point of giving Narcan is to stimulate the respiratory drive. I read between the lines, and it's kind of like you don't have to wake them up, just get them breathing on their own again so that way they can perfuse their own brain matter with oxygen. So, quoting the article, in summary, naloxone, which is Narcan, I'm sorry if I didn't reiterate that, but if you didn't know, that's what it is. It does not have a likely benefit in patients with confirmed cardiac arrest who are not breathing and do not have a pulse, who are receiving standard resuscitation. Again, that's including assisted ventilation, CPR, all the things. Quoting further on, and there are some reasons to suspect that this practice may cause harm by increasing cerebral metabolic demand at the time of hypoxemia and acidosis. If the patient is definitely pulseless and receiving standard resuscitation, including assisted ventilation, naloxone, Narcan, is unlikely to be beneficial. Because there is a theoretical basis for harm, standard resuscitation alone is indicated. So, my whole point, I'm not saying all this stuff with my small knowledge of the pathophysiology of Narcan, what it does, and my knowledge of the ACLS algorithm and how to work a code, all that. I'm not saying that. I'm saying it because there's evidence, there's research, and if we can do better, we should. Moving on to what I wanted this whole podcast episode to be about besides all of that. I initially titled this, and Mom, if you're listening, I'm sorry. I'm going to say something you don't like. I don't think it's bad. I titled this episode as Owning Your Screw Ups because it's something that I was told while I was doing my paramedic clinicals and it stuck with me. But I'm kind of transitioning into the idea of just in general owning your mistakes in the aspect of your protocols and having patience with providers who have a weakness where you may not have it because we all have weaknesses. The new hire training and new student precepting, all that, that is your best time to make mistakes because then you learn from infield providers versus when you're on your own. I always take everything they do, everything they're trying to do, all of this stuff, and with the mindset that like sometimes they don't know. Being able to kind of instill in new hires that yeah, we're gonna make mistakes, but we're gonna move past this. For instance, I think back to I think back to when I was doing my first ride time on the ambulamp. We had a critical call, and the medics like, "Hey, just go ahead, go inside, see the patient. You know, start your own assessment." They for whatever reason, they decided that I was competent enough to be able to do that. I bless their hearts. But because I was so new and EMS was such a wild concept, I literally could not grasp the idea that we are called to this house and people expect us to just show up and just walk in their house. So, with the backbone of my southern upbringing and my mama always taught me, you don't just barge in somebody's house, you knock and you wait for them to open the door. And I went to this patient's door and I knocked and I sat there and waited. And I heard the medics still doing their stuff. They're getting the stretcher, all that. And I sat and I knocked again. And as the medics are coming up to the door, I'm knocking and I turn around and I just smile at them and I'm waiting. And one of them literally said, "What is she doing?" and moved me to the side and like opened the door and said, "EMS." That idea of like just take a second. We talked about it after, and they were like, "No, you're an EMS. You need to be assertive. Go to the door, knock, try to open it, you know, in a safe manner because you never know what's on the other side." But moving on. Or when you miss something in the treatment plan you have for a patient, the biggest thing is just be honest at patient handoff at the ER, or if you're confronted by your supervisor because they're doing QA, QI on your charts. The biggest part of owning your mistakes is keeping a reputation of integrity in not only how you treat patients, but how you're able to facilitate criticism and just being able to own up to what you did. So we recently had a call and I did the 12 lead ECG and I didn't call a STEMI on it, but I saw the rhythm and I'm like, ooh, that looks weird. So we got to the ER. I showed the nurse and I'm like, hey, I didn't call a STEMI on this, but like I saw this. I don't know. It just looked really weird. And then he looked at me and he was like, "No, that's a PVC." And I looked and I was like, "Oh, that it is." So, did I feel like a moron? Absolutely. Did he sit there and fuss at me and tell me that I was a terrible medic? No. Honestly, we laughed about it. I got my signature from him, told the patient, "I'm sorry you don't feel good. Hope you have a better day." And I moved on with my life because oopsie doopsie, it's not a big deal. But you push the wrong dosage of a medication and your patient suddenly deteriorates and you've dropped their blood pressure. That is a big deal. And that's a little harder to kind of bring up or to point out, or when you do your handoff at the ER and the doctor's in there and he's asking you stuff and you say the medication dosage and he looks at you, he raises his eyebrows. That hurts. But at the same time, own up to it because not only is it your pride and ego, that is patient care that you could be compromising because you don't want to own up to what you did. And God forbid that you're not honest on your report because you want to save face. You don't want to get a nasty message from whoever's reviewing your charts and all that stuff. It's not worth it. So aspect number 2 is also part of owning up to your mistakes is being able to take criticism, talk over a call, and not in a way of being able to justify everything that you've done and that you're right, you have the superior. No, being able to do this with the mindset that either you can learn from it or you can discuss it. Maybe somebody else has a better idea, that kind of stuff. If you work with me, after almost every single call, I try to go over like, hey, anything that could have gone better, any advice, any criticism, just because you never know. In a recent event, me and my partner recently had a pretty intense call and it was good. It was awesome. I was lead medic and I was, you know, given a couple of things that I wanted and I'd said something. I saw my partner kind of like look at me a little weird, but she went along with it. And so after the call, I was like, hey, if you had disagreed with that thing, you would have said something, right? But it came down to like, she said, I respect you enough that I went with it. And I told her, I was like, next time, like, okay, in that moment, we didn't really have the time, and I was able to talk about it after, but we need to be able to talk about this kind of stuff. Just being able to have that open discussion. But even like if we drop off a patient like that patient we had, if I'm second guessing my patient care treatment and I'm kind of thinking like, what if I had done this? What if I hadn't done this? What if going through all the hypotheticals, I'll go to the doctor, go find him, and I'll ask him or her, should I have done something else? Or do you have any advice? And sometimes they bring up things that like one time it was so blaringly obvious that I didn't do that I looked at him and I was like, I am so sorry. I am dumb. And we'll kind of have that discussion. And is it embarrassing whenever I forget something? Yes. Does it make me a better provider to be able to admit that, like, oh man, I missed that. That's my bad? In a way, yeah, because you learn from your mistake. That's a big part of trying to do better is not just you study all the things, you listen to all the podcasts, you read all the books. It's taking those times when you make the mistake and learning from it and growing. Because if you don't grow, you get stagnant. So, like with that call, it came out as a choking. We get there and the patient's coughing, which is great. They're not actively choking in that moment. We don't have to do the Heimlich right now. So I've been talking to the husband and she started choking on one of the pills that she takes every night. And she never lost consciousness, never had any airway obstruction, so she never like stopped breathing, nothing like that. But right now she's coughing and she has wheezing all over the place. So started on a little neb treatment that she does take on a daily basis, but she had not taken since like 2 days before, something like that. Irrelevant. And starting that, and she didn't get better. Long story short, we load her up on the stretcher, get her in the back, start a second breathing treatment per protocol, and we're kind of getting along doing things. We start going after we get a line, and she's starting to wig out. She's trying to take off she's not even using like her little neb treatment that she can hold. I move her to a mask, and she's not tolerating that at all. So I'm thinking like she's still wheezing, she's still struggling. We can't do a CPAP because she's too, like, she's not going to be able to tolerate it. So I kind of started moving on from like, okay, this isn't just an asthma exacerbation, which she has an extensive history of and has been intubated before. She is having an anxiety attack on top of all this. So like I went mentally from our asthma exacerbation, did not give her an epi-IM injection to do all the alpha and beta receptor shenanigans that it does. Because like one, her pressure is 157 over 101. Ooh ma, I need you to take it down 3 notches on top of now like she's wigging out. And so I looked at my partner, I'm like, hey, we need to drop some first aid. And I didn't say it out loud, but we're moving from one protocol to the next. That's that moment when she kind of looked at me. So without saying out loud, we switched from the asthma exacerbation to anxiety, which it's totally justified and it's what the patient needed. Very long story short, she ended up like her blood pressure went to the last one we got was like 123 over something good, and her heart rate normalized, and like she didn't even stop breathing. Everything worked out, but she just went to like completely unconscious for a second. And my partner and I kind of panicked for a slight second, and my partner gave her like a good stern rub, was like, ma'am, administered copious amounts of ma'am. And like she was able to kind of respond a little bit. By the time we even got to the hospital, it was a solid like 3 minute span of time. She ended up like she was trying to take everything off. She was kind of getting squirrely again. So when I called in, I explained that like, hey, we gave her this first set, and now she's kind of not really with it, and she's a little unresponsive, but everything's fine. She's breathing. We just have like we had the BVM with the seal over her, not bagging her because she's breathing on her own. All of that. We get to the ER, and I give the handoff report, and I mentioned, hey, we gave the 2.5 of first set, and I saw the nurse look at me and give me a look. The doctor it didn't even phase him, and so I went and I talked to him and explained like, hey, we couldn't do a CPAP because she was wigging out. She wouldn't have tolerated it. Hey, we wanted to start a mag drip, but blood pressure, this, that, and the other. And by the time everything normalized, we were even able to like think about starting a mag drip. We were literally pulling up. So these are the reasons why. And he totally had my back. He totally understood. Everything was fine. I ended up finding out later on that she was still wheezing. She was still just not having a good time like she was with us. So the doctor tried to put her on CPAP like we wanted to and ended up giving her Ativan and then put her on the CPAP and ended up, her last result I found, she went to the ICU for an overnight stay, and everything I did was totally, one, backed up by my protocol. Two, I talked to the doctor. I didn't leave there feeling like, oh man, I screwed that up. No, like I was able to talk it out. We had a good conversation about it and everything worked out. The thing with my partner, it's not that she was second guessing what I was doing. I should have been like, "Hey, this is anxiety now. Like, let's go ahead and give some Versed." Also, Versed has some smooth muscle reactor effects, whatever. A lot of pathophysiology I don't want to explain, but just kind of explain that like it's going to help her in the long run. This is what she needs right now. And like the doctor said, that lady's probably always teetering between when she goes into like that asthma exacerbation like she was in because she looked rough. She was pale, clammy, diaphoretic. She's always probably teetering between like going unconscious and getting tired of breathing like she was. Like right before I switched her to the rebreather mask with the albuterol treatment still going, she was like head bobbing and then she started trying to fight us. So instead of letting her tire herself out and then we got to throw down a tube because little mama couldn't handle, we just give a little bump. We just kind of sedate her just a touch. And he even said, the doctor said, the 2.5 of her said should not have completely took her out like that. So my partner and I talked about it, and it was kind of like this thing of like, okay, I get it. I wasn't fully with you in that moment, but everything worked out, and it all turned out well. And in my chart, I'm able to justify all of that. But we had a call. This is the thing that kind of gave me the idea for this entire episode. It was respiratory distress. We get there, lady's kind of wheezy. I don't know why we had all the wheezies in one day, but we did. So she's kind of wheezy. I checked out her vitals, everything, and she's saying she doesn't want to go. I kind of convinced her to go because I told her like if this was my mom, I would not let her stay here. And she was like, "Oh, okay." Then we stood her up, and she's like, "Whoo, yeah, I'm feeling a little short of breath. I think." I'm like, "Okay, just sit down. Stop doing the thing. Stop talking. Thank you." But we get her in the back, and I'm kind of going down respiratory because she has a significant history. She's also saying she's got tightness in her chest. And so I'm thinking, like, the 12 lead looked fine, but what if we miss something? She's got the chest pain. It's not going to hurt with the respiratory system setup she got going on right now and her symptoms. So we'll give aspirin. We had a new hire EMT, and I told him, I was like, hey, go ahead and drop aspirin. And the partner I had that day, they were like, well, no, she takes it on a daily. And I thought they heard me say, like, well, no, in our protocol, literally just read it like the day before. I said, like, even if they take aspirin on a daily, we can still give it. But miscommunication, this, that, and the other, the patient turned out fine. Everything worked out. I was 99% sure it was a pulmonary embolism, like she was having like a clot in her lungs. I didn't know. So I'm just trying to do the things for patient care. And that way, whenever it gets brought up, of like, if this chart gets reviewed, like, hey, why didn't you do this thing? I could at least say I did. So it kind of just reiterated, like, I need to know my dosages. I need to know my protocols in and out because it's little things like this that, like, if that had been more detrimental, we would have been up a creek. And not even just for like our pride, our ego, but if she needed it for whatever she had going on that we couldn't immediately be able to pinpoint in that moment, that's patient care being compromised. So, what I'm trying to get at is that we have protocols. Following protocols doesn't make you a quote cookbook medic. I think it shows that you're able to say that you trust evidence based studies and data, and you rely on a medical director, an MD, or DO, whoever it is, who is sticking their neck out with the liability of you and your fellow providers to use critical thinking capabilities with practicing medicine. In EMS, from the EMT all the way to the flight medic and everything in between, our job as healthcare providers and clinicians is to trust science through studies, tests, data, overall evidence based research through our protocols that somebody else has written that's above our pay grade that shows what helps and what doesn't. And medicine changes all the time. The field of EMS is relatively young, and like in the short time that EMS has even been around, things have changed. For instance, providers in the good old days with the good old boys, like they used to say that tourniquets were bad because they cause crush injuries or whatever it is. But now we understand that the red stuff that is literally spurting out of the patient, and that stuff needs to stay in the patient because that stuff carries the hemoglobin, which carries the oxygen and perfuses the patient. And if they don't have it, they'll die. They also used to just dump fluids into every trauma patient by the liters. And now we're realizing that just dumping a bunch of fluids and turning the blood pink is literally going to kill them because, again, the red stuff needs to stay red inside of the patient. They also used to give all stroke patients and myocardial infarction, which is a heart attack. Sorry, wanted to use a big word. They used to give all those patients O2, but now studies are showing the detrimental effects of giving too much oxygen, causing vasodilation, the effects of cardiac demands, worsening the ischemia, the damage, and all of that stuff. So things change. And I mean, I'll even say like the whole tangent I have with Narcan. Who knows that in 20 years that may not even be like the same idea. Things change all the time and we have to be flexible with that. But at the same time, keeping our concrete foundation of whatever agency you are, your protocols are what you follow. And with your protocols, like your medical director doesn't just sit at a desk and ponder, what can I make them do now? Or wake up at 4 a.m. and hurriedly like scribble down ideas as they exclaim, Eureka! This is what must be done based on my medical practices and studies alone. Like, no. Again, this person with extensive and expensive schooling and all the years that they've put into this, on top of research, data, studies, tests, conclusions, all of these things, and all the liability associated with it, they're sticking their neck out so that way you can take their license and, as an extension, practice in the field of medicine in the streets, in the houses, in all the places that we go to. So, like, if you have your protocols, you do the things based on patient presentation, your findings, all of the stuff. If you show up at the ER and you're asked, why didn't you do this, that, or the other? Or why did you push this medication? Why did you decide to? You have the ability to say, it's because I followed this protocol, which tells me to do blank. And even in some cases, this is why I did not do blank. And you're fully justified in what you have done based on your protocol from a medical director. And as a side note, especially if your medical director works in like the ER that you drop off at or hospital you drop off patients to, whatever, you should know what they look like because from my personal experience, back when I was like early in my hiring process at the agency that I work at, and this is my bad, I had no clue what our medical director looked like. So it's like 3 a.m. We drop off a patient and I'm given handoff report. And I look over it and I didn't know our medical director sometimes would wear like the scrub top with like khakis or something like that. Some of the ER doctors do. I didn't know that. I just look over and I see this guy and I'm like, okay. And he starts asking me like, oh, well, what was the dosage of the medication they overdosed on? What was this? What was that? And I'm trying to like give short answers because again, I don't know who this man is. And I'm like I look back from him to the nurse and I'm talking directly to the nurse. Not a clue. This is our entire medical director. So then I give the handoff report. Everybody kind of leaves the room and I'm looking around for somebody to sign my tablet. Like that way I can get a signature showing that like, hey, I dropped off this patient. I'm trying to clear up because again, it's 3 a.m. And the guy, like, he looks over, he's like, do you need somebody to sign? I was like, yeah. Not telling him, are you even able to sign? So I ask him, like, hey, what's your name? And he laughs and he gives me his first name. And I'm like, who is this guy who thinks I should just know who he is? Then he tells me his last name and I'm like, oh, okay. And I put RN at the end. And then he laughs and he's like, no, it's DO. And I'm like, oh, okay. So I respell his name with the DO, like part of the spelling of his last name. And then he laughs. He's like, no, it's not RN, it's DO. And I'm like, oh, okay. Also, still thinking, are you even allowed to sign this? Not knowing I'm so dumb. I get back in the truck and I look at my partner for that night. I'm like, hey, who was that guy with the khakis in the ER room? And she was like, Alexis, that's, and she says his name. And I'm like, oh, okay. And I looked at her, I'm like, oh God, is that our medical director? She was like, yes, Alexis, that is our medical director. I did not have the humility in me to go back in and apologize. We ended up dropping a patient off soon after. And I went to him, I found him. I was like, I just want to say I'm so sorry. I had no clue. I'm so sorry. I literally am an extension of you in this field. All of this time and effort you've put into like approving our protocols and doing all this stuff. I'm so sorry. I'm not dumb. And he laughed and like he laughed about it. He actually told our training coordinator guy and they were laughing about it and like I can laugh about it now, but Jesus, it was the worst moment of my life. Hands down, do not recommend. I'm going to give one more little story because this literally like it is the reason why when I show up at the ER and I'm explaining what I'm doing and I'm given that look or like the eyebrow raise, again, the ER staff doesn't see your protocols. They're not dumb and they know what medics can and can't do. However, they don't know your protocols like you do or you should. Keeping this very short, I was doing my paramedic clearing times. I was in the back by myself on every call. We get a call for a guy. I don't remember what the chief complaint was. We get there, and the wife is no help giving us any history, just that he's just kind of like this. He looks like he's having a stroke. Quick stroke assessment. He's not having a stroke that we can see or anything like that. Put him on the cardiac monitor, and his heart rate's in like the 30s. So I'm like, oh God. And this was before I've had like this revelation of like, hey, treat your patient, then transport. Anyways, throw him in the back. My partner helped me get a line. I started some atropine, just pushing atropine, doing that. His heart rate got better. Everything started coming up, but like he's still struggling. And then he gets real sleepy. And I'm like, hey man, why don't we stay awake? Don't do this today. In the meantime, like I had a temporary crown put in because I was supposed to have a root canal. And I'm like chewing my gum so hard that like when he kind of just went unresponsive and I threw the pads on, started doing all the things which I already should have done. But again, I neither here nor there. Owning my mistakes. So doing all this stuff en route, my crown fell out like with the piece of gum. So I had to throw away that. So I'm already amped up. That happened. So I'm calling the ER and I'm like, hey, he's not doing good. Explained everything. Get to the ER. The doctor isn't even there. They're trying to put us in a regular room. I'm like, hey guys, he's not doing good. We don't need to be in a regular room. We need to be somewhere in case you have to intubate because I'm also bagging him in case you didn't notice. I was very sassy that day. So get him into the room. I'm giving a handoff report to the nurse because the doctor is still nowhere to be found. And I'm halfway through my report, and the doctor comes in and he's like, start over. I was like, okay, I already had beef with this doctor. I don't know how to know my place or something like that. So I start over my report, and in the middle of saying, like, yeah, his heart rate increased, his blood pressure got better, all this stuff, he literally looks at me and says, wait, so why did you give atropine? And I don't know, again, I don't know if it's because my crown fell out and so there's this gaping like hole in my mouth. I'm already amped up. I just looked at him. I was like, I don't know, man. Why would you give atropine? I think I heard it one time that giving it helps with the heart rate, but I don't know. And then I looked at the monitor and I'm like, since you guys haven't done anything for him for the past like 5 minutes, now his blood pressure's trash and he's probably about to code because his heart rate's back down. And then the doctor looked up. He's like, "Oh, I'm," and started yelling out all these orders. And I got pushed to the side. I was like, you know what? Y'all are done. I'm done with y'all. Again, I don't know how to know my place. But reinstilling, like, I know what I was supposed to do because of my protocol and because of what I know, because of this, that, and the other. So I'm justifying what I did. I mean, I'm not trying to sound this way, but because I did the right thing, it just was so much. And then I had to go in the bathroom and like spit blood out of my mouth because my crown was like bleeding. It was not a good time. It was not a good time. But again, reiterating like I know what I did. It was the right thing. I followed what that doctor had told me what to do based on my protocols, and here we are. I don't know why you're questioning me because this is the right thing. And if you want to take it up with somebody, I'm not the one. And today, especially that day, it was not the day. Protocols are not designed as a box to put you in. They're boundaries of what your medical director has stated for you to do. Do I agree with every single protocol in our protocol book? No. But also, like, in these protocols, if you follow one and you need to change it, I mean, go with what the patient needs. You can't just read a page on a symptom from a protocol and follow it. As a provider, EMT, paramedic, flight medic, whoever you are, you're given a specific, rigorous, or at least it should be, schooling and testing process which allows you to facilitate the tools in your magic toolbox and in your noggin to assess the situation, understand the whole picture to the best of your ability, treat your patient, and bring them to the ER for better patient care. Basically, it's just downright lazy to not review your protocols and cardiac rhythms and dosages and all of those things when you have the time, even if it's not on shift. And I'm calling myself out on this. If you don't know what that rhythm looks like whenever you're just flipping through a book or you're Googling things, whatever it is, if you don't know it right then and there, you're probably not going to be able to know it when you're staring at a patient and you're drawing a blank. And God forbid it's a kid because of all of their weight-based dosages and their everything is just so much more complicated. Maybe that's just me. Next, I don't really care if you've been in the EMS since the eon of time. You will never know it all. Like I've said, complacency kills. It kills a desire to learn and it creates an avenue for burnout where you go from treating your patient, again, even if it's Zofran for a little bit of nausea, that's probably because they've been staring out the back window, facing backwards, You go from doing that to, like, I equate some burnout medics. You're a FedEx package delivery driver with patients in the back who you pick up a patient, you drop them off, and then you shove the tablet in their face and say, sign here. Do better. Personally, for protocols, I keep a little handbook in my pocket where I've written out all of our protocols, all the dosages and stuff. And it saved my bacon a couple of times. Because, like, there was one time we were on the way to a seizure call for a 6-year-old having a seizure. And on the way there, like, I'm going to be honest, I'm freaking out because I'm like, oh God, a 6-year-old. Oh God, seizures. Oh, doing all that. I'm able to, like, calmly open the book, find the dosage for Versed, look at the pediatric dosage, calculate what they probably weigh because I don't know what the patient looks like, and then be able to, like, have that exact dosage for if they are still seizing. This is how much Versed I'm fisting drop. Instead of getting to the patient and trying to remember off the top of my head, like, oh God, what's that pediatric dosage for? It saves time. And there are plenty of resources to help you out, such as there's an app called PediStat. You have the Handtevi resource, which is amazing. All of these things, but they cannot substitute your protocols. And my last little thing about owning up to your mistakes, being able to justify what you've done, what you haven't done, but being able to say, like, man, I screwed that up. Don't beat yourself up after a call. Learn from your mistakes, learn what you did wrong, what you could have done, and then grow from that. If you're not growing, you're getting complacent and you will wither away. Being able to criticize yourself, even if everything went well, and being able to look at yourself in the mirror and say, like, man, there are things I can work on because there's always something you can work on. And if you don't, you become a paragod. This episode was very long. I'm sorry. If you've stayed around for this long, I am going to include some little bloopers at the end because I'm willing to laugh at myself and I'm just a mess. So, guys, if you have any questions, comments, concerns, future topic ideas, please email me at 22 at the lips podcast at gmail.com. Again, that's 22 at the lips podcast at gmail.com. Thanks. Never stop learning and be safe out there, friends. So, like, as much as I want, oh God, no! I literally just made this. No, the coffee stain. Jesus. Oh. They also used to say that all trauma patients gets flu. They also used to say, "Ah, don't know why my mouth hole won't work when I try to say words. What's wrong with me?"